a little bit. Let's sit down and we're going to talk about shock, okay? But before we can think about the abnormal state, it's important that we understand normal cardiac physiology and the physiology of perfusion, because that's what shock is, right? It's malperfusion to tissue. And so before we can understand malperfusion, we have to understand how do we get normal perfusion in physiology. And really there's two things that we look at for tissue perfusion. One is going to be your cardiac output. Some people just call it CO for cardiac output. Other people say flow C, which is also cardiac output. And then you put your little dot on top because that's the amount of cardiac output over the course of a minute. So cardiac output's one thing. And then the other thing is your peripheral vascular resistance. So what's the tone of the vessels? Because obviously you can imagine if there's vasoconstriction, there's going to be less perfusion to tissues versus vasodilatation. When the vessels get big, there's going to be more perfusion to the tissues. So we have to think about both of those components and understand perfusion from both cardiac output and peripheral vascular resistance standpoint before we can even start thinking about states of malperfusion. So let's look at cardiac output now. We'll call it CO. Cardiac output is made up of two things, right? So cardiac output is how much blood flow comes out of the heart over the course of a minute. And that depends on both heart rate and stroke volume. For URTs, the equivalent in RT standpoint would be minute ventilation. So minute ventilation. So that's how much you ventilate in a minute. Cardiac output is how much blood comes out of the heart in a minute. And it depends on heart rate and stroke volume. Well, heart rate is self-explanatory, right? It's how fast the heart's beating. That's like your respiratory rate. Stroke volume, on the other hand, contains three components here. Okay. It contains preload. That's how much blood gets into the heart on a sort of a beat by beat basis. It's afterload. That's how much pressure the heart has to beat against. So if you think about driving down a highway, if there's an accident up ahead and now the cars start to pile up, that's the afterload. The preload is how many cars are actually coming onto the on-ramps behind you. So preload is the blood into the heart. Afterload is how much pressure does the heart have to beat against. And then the final one is going to be contractility. And that's essentially how strong is the heart muscle when the heart pumps every single time. What's the strength? What's the efficiency? What's the effectiveness of that contraction when the heart pumps? And this is really important to understand this normal physiology, because when you guys manage shock, you actually manage these things all of the time. So kids who present in different states of shock present with problems either with heart rate, with stroke volume. And if it's a stroke volume problem, it's either a contractility, an afterload, or a preload. And it's important that when you think about shock and you see a kid who's got malperfusion, you start to tease out, why are they malperfused? Are they malperfused because of one of these things, or is it a problem with, peripheral vascular resistance? Okay, so let's look at one of those components. So preload. Think about what situations where you think there may be less blood flow, less volume coming to the heart. So preload, decreased volume to heart. And you can all think about different clinical scenarios where a patient might be dehydrated, right? So vomiting, diarrhea, hemorrhage, right? And then DKA, where you have plus urine, you often have plus vomiting, and the patient becomes dehydrated. The reason it's important when you're thinking about shock to understand shock from a physiologic basis is because that dictates our management. If the problem's preload, how are we going to treat the kid's shock? Fluid.